Okay, so I think we've got 70 people attending now. So I think we'll just crack on in the interest of time. So thank you to everyone who's joined us for a webinar about the new inclusion of NoLap patients into the National Emergency Laparotomy Audit. I'm Lindsay Pearce, I'm the surgical lead for NELA, and I'm a consultant colorectal surgeon at Salford in the Northwest. With us today, we've got a number of couple of other speakers, and then I've also invited along other members of the project team because this is quite a change to the audit, and I thought it was helpful to have a bit more breadth of people available for the Q&A session. So just going to go through who's logged in so far, and then there will be probably a couple of others who will log in a little bit later in the session. So if we can go first to Christine.
Thanks, Lindsay. Hi, everybody. My name is Christine Taylor. I'm the NELA project manager.
And Angeline.
Yeah, I'm Angeline. I'm an advanced nurse practitioner at Salford, specialising in frailty and perioperative care of older people, and I'm a NELA fellow on the project team.
And Eno.
Thanks, Lindsay. Hi, everyone. My name is Eneng. I'm a NELA fellow, also an anaesthetic trainee, currently based in St George's Hospital in London. Thank you.
Thanks, Eneng. James.
Hi, everyone. I'm a general surgery registrar in the East Midlands North Deanery and a NELA surgical fellow looking at inflammatory bowel disease.
And Hannah.
Hi, I'm also a general surgery registrar and a NELA fellow, and my special interests and the things I've been looking at with NELA have been futility in surgery.
Great, lovely, thank you. So we've got almost 100 people now joined the webinar. Just before we start, if you've not done one of these webinars before, we submit questions and comments through the Q&A tab, and we'll come to these at the end of the presentations and have a Q&A session which Christine is going to chair for us. If you have any problems, just exit and restart Zoom. A recording of the webinar will be available with all the other webinars that NELA have produced, and it'd be really helpful to us if you could complete the post-webinar survey which Christine will send around. So without further ado, I'm going to hand over to Angeline first, who's going to give us a little bit of background around patients who do not undergo emergency laparotomy.
Thanks, Lindsay. Yeah, so just to kick off, I'm going to chat briefly about the literature behind NoLap and what we've drawn upon when planning the NoLap NELA project. So I'm sure we're all quite familiar with the numbers here on the screen. Around 24,000 people undergo an emergency laparotomy each year across England and Wales. We've seen consistent improvement in care processes and patient outcomes over the past decade, and this has resulted in a reduction of in-hospital mortality, which has fallen and plateaued at around 9%. And this is a combination not just of the improved care processes, but also through refined decision-making. We've seen that the number of patients with an extreme risk has fallen consistently over the past few years, meaning that we're not offering or we're not proceeding to surgery in some patients where it might not be in their best interest. But we know from studies such as the ELF study, which was the first to demonstrate that there is an association between frailty and adverse outcomes. So older people, particularly those who are living with frailty, are more likely to stay longer in hospital. They have a higher risk of being readmitted to hospital. They have higher 30-day, 90-day and 1-year mortality rates, and they're susceptible to functional decline after surgery. And many more studies, along with the NELA dataset, has shown us this since ELF. And this has helped us to further refine decision-making, and again, perhaps avoid surgery where it's not deemed beneficial. But then who are this group who don't have surgery? And we refer to this group of patients as the NoLap group. How do we define NoLap? Well, this definition taken from a study by McKilvey et al. They defined a NoLap patient as one who presents with an acute abdominal pathology, treatable by emergency laparotomy, but who does not undergo surgery. And I'm sure you'll hear throughout the course of the presentations how we've tweaked and refined that definition for this project. What do we know so far about this group of patients, this NoLap group? Well, there have been 3 studies that have been published and a further study which is pending publication. I'll just give you a brief overview of all of those now. The first was the Perth Emergency Laparotomy Audit. This was published in 2017. It was a multi-centre audit collecting data prospectively from 10 of the 16 hospitals that provide emergency laparotomy in Western Australia. Data was collected over a 12-week period, and that included patients who'd had surgery, and also NoLap patients were identified through the Western Australian Audit into Surgical Mortalities process. The prevalence of NoLap in this cohort you can see was 6.6%. Of the 13 patients who didn't undergo surgery, 10 were aged 80 or above, so the majority, the older population. 4 had ischemic bowel, making this the most common diagnosis. And the paper tells us that around 70% of the NoLap patients had died within 5 days of the decision, so a fairly high mortality rate. The authors concluded that non-operative cases had almost doubled since the introduction of WASM, and that these patients therefore should be included in future prospective studies that were analysing outcomes around emergency laparotomy. This was followed by a Scottish study in 2019, McKilveen et al., in a single centre study, prospectively collected data with a target of 100 consecutive NoLap patients. This resulted in a final cohort of 314 patients, giving a prevalence of NoLap of 32%, surprisingly higher than seen in the previous. There was some exploration into the decision-making process in this study, and the authors found that poor fitness was the most commonly documented reason behind a NoLap decision. The study also highlighted that patients receiving a NoLap decision were less likely to have a consultant involved in that decision-making process. Surprisingly, in this study, 26% of NoLap patients remained alive at 12 months. The authors concluded that the care leading up to a NoLap decision is substandard when compared to those patients who have surgery, that the NoLap group is significant in number and a proportion do survive, but they questioned what is poor fitness objectively when this is a reason behind a decision. What does it actually mean? The next, a Danish study, again single-centred prospective study. The primary aim of this study was to estimate the prevalence of NoLap. They collected data on 252 consecutive patients where an emergency laparotomy was indicated and found a prevalence of NoLap of 8.3%. These patients were older, comorbid, and had higher ASA scores. Again, some exploration of the decision-making process found that poor functional performance and futility were documented as the main reasons behind the decision. Mortality much higher in this study. 95% of NoLap patients died by 30 days and all had died by 90 days. The authors concluded here that there are potential cultural differences in the way NoLap patients are triaged and the decision-making behind that. They recommended larger multi-centred studies to further explore this population. Enter then the ELF2 study, the results of which hopefully will be published in the near future. This was a UK-wide multi-centre prospective study. It collected data over a 6-month period from 62 NHS hospital sites across England, Scotland, Wales and Northern Ireland. The study recruited 825 patients, showing that it is possible to collect data on this group, quite a high volume of patients in a fairly short period of time. The ELF2 cohort were, again, older, living with comorbidity, a high percentage living with frailty and advanced malignancy. Digging into the decision-making process, we found that only half of patients had a recorded risk assessment score as part of the NoLap decision. There were diverse and sometimes subjective reasons behind the NoLap decision-making. A multidisciplinary team and patient involvement was lower than expected. Only 11% of cases were discussed with anaesthetic colleagues, and even less so with other specialties. Again, some surprising results here with mortality. High, but death doesn't seem to be inevitable. A fifth of patients survived to 90 days, and many returned home to their usual place of care. To summarise these studies, the NoLap patients do appear to be older, multimorbid, with high levels of advanced malignancy and frailty, meaning that this group of patients potentially are identifiable. There is some opportunity for some preemptive planning in this group. It seems the approach to NoLap decision-making is not standardised, and there might be room for improvement. Some conflicting results around prevalence and mortality, but certainly it seems that some patients do remain alive at 90 days and 1 year, which calls into question, what is the best approach to management for these patients? How can we optimise their outcomes? But there's still a lot that we don't know. We still need to dig down further into how this decision is being made, who's involved in making it, who's driving it, why is a NoLap decision reached, and what happens next to this group of patients. We know quite well from the NELA dataset the patients who have surgery, which ones survive and who dies. We've got some idea from the NoLap data of which patients are likely to die, but it's this group in the middle that we need to understand better. Those who may have died with surgery, but are alive without. Potentially, is NoLap a viable alternative to surgery for some high-risk patients? Happy to answer any questions at the end. Please do input them into the Q&A panel, and I'll hand back to Lindsay now. Thanks.
Fantastic, thanks Angeline. So that really nicely sets the scene as to why the HGRIP have asked us to collect this data. So I'm now going to hand over to Ineng Low. Ineng is our NELA fellow who's done an extraordinary amount of work making sure that we get this as right as we possibly can when we introduce collection of this data set in April. So over to you, Ineng, for the next part.
Cool. Right, thank you, Lindsay. In the next 10 minutes, I'm going to give you an introduction to this NoLap audit and give you an overview, and we'll answer any questions after the presentations. So the aim of this NoLap audit is to look at the non-operative group of surgical patients and hopefully to build a long-term, more robust database, just like what we had with the operative patients. So we are aiming to roll this project out in April 2024, which is in a month's time, and we'll start off with patients who present with suspected bowel ischemia and bowel perforation to keep things simple for the first year. Later on, as things start to pick up, we'll then include all other diagnoses in later years. So working towards this NoLap group, the NELA project team has put in a lot of effort throughout the year, and among this, we have organized a virtual consensus meeting where we had multidisciplinary experts from all over the world coming through, and a lay representative on a panel expert, with the aim to establish the definition of NoLap and also to identify essential care processes for this group of patients. We then continue on to set up a NoLap working group to develop key standards, question proforma, and case ascertainment pathway, which we'll go through in the next couple of slides. So on the top right-hand corner in the next few slides, I have actually put up a QR code where you can scan, and it will lead you to the NELA web page with the important documents for NoLap that we've put together. So feel free to scan the QR code and download documents for your reference. So after multiple discussions with the NoLap group and from the consensus meeting, we have defined NoLap as a patient who presents with acute abdominal pathology, needing surgical intervention, that would meet NELA inclusion criteria, where a decision is then made that they will not undergo emergency surgery. In the first year of the NoLap audit, we will include patients who are aged 18 years and over, so adult patients, patients who present with a diagnosis of bowel perforation or suspected bowel ischemia, where surgery is indicated, but did not undergo abdominal surgery, so either laparoscopic or open surgery during the single hospital episode where they're being admitted. We will exclude patients under 18 years of age, patients who have undergone emergency or elective abdominal surgery, both laparoscopic and open, patients whose bowel perforation or ischemia has been managed by interventional radiology or any endoscopic procedures, and any patients who will be excluded from NELA based on the NELA exclusion criteria. So from the consensus meeting and the discussions in the NoLap working group, we've identified interesting key themes and then further developed them into key standards. So there'll be 5 key standards that we'll be looking at on the first year for NoLap, and 3 of which is the current NELA standards and 2 new ones, when Lindsay will go through them in further detail in her talk. In terms of how cases will be captured, so clinically, this will vary between trusts. As a suggestion, we think it will be helpful to appoint a NoLap lead in your trust, and it can be anyone from different specialties. It doesn't have to be a consultant, where this NoLap lead will do daily checks with the on-call surgical registrar to try to identify NoLap patients and enter them into the database contemporaneously. This is a suggestion from the NELA team, but we are open to any suggestions from the floor if you have any. From an audit point of view, we will be looking at HES and PDU data for wills, and will include patients who have completed records. We have identified diagnostic codes to identify patients who present with suspected bowel ischemia and bowel perforation, and through that we'll identify to try and capture NoLap patients through the NHS digital data. So for the first year with the outlier policy, HQIP has published an updated outlier guidance document, and to allow for testing and to allow the process to embed, we will not be enforcing the outlier analysis in the first year, but we'll be monitoring participation from all the trusts. And for future years, we'll update in terms of what outlier metrics we'll be looking at. So I'll put up the QR code again for people to scan and download documents for your reference. And we're happy to take any questions at the end of the presentations. Thank you.
Fantastic, thanks, Enang. Now we've got 130 people who have joined. We've only got a few questions that are coming in across the Q&A at the moment. I'm going to now whiz through the standards. As Enang said, these are all documents that are available on the NELA website. I think someone's having a trouble using the QR code, so if that QR code isn't working, we can maybe email out the direct link to the page that all these documents are placed on. But as I say, the standards document is available there. Right, let me share my screen and we'll continue. Okay. Can you see my screen? I hope you can. I need to get rid of the chat though, wait a second. There we go. Okay, so when we look at the standards, there are some different terms used within the standard document. So there is a standard, which is the audit standard against which NELA benchmarks. That standard comes from a source, which is either a guideline or a policy or some national directive where there is a published document by a list of experts with an evidence base to it, from which we take the standard. So there is a source document. There is also a RAG rating that is associated with that standard. And we've tried with the RAG ratings for the NoLap to really match them against the ones that we have for the emergency laparotomy patients. And then how we measure that standard is through a process measure. And that process measure is what comes from the questions that we ask within the data set. So the standards for NoLap will be risk assessment, frailty assessment, CT scanning and reporting, and then 2 new standards, which are advanced care planning and end-of-life care. And these are probably 2 areas that, as clinicians at the moment managing emergency laparotomy patients, we don't tend to get too involved with. So these will be new and different. So if we go through risk assessment, the standard is the proportion of patients in whom a risk assessment was documented prior to non-operative decision. The source of that standard is the high-risk general surgical patient, raising the standard document that was published in 2018, and that appears several times across the standards that we're benchmarking against. It also comes from the NC pod, knowing the risk document, which was published, I think, just before the raising standards document. That translates into a RAG rating of greater than 85%. So more than 85% of patients with a formal assessment of mortality risk will be RAG rated as green. And you can see the boundaries for amber and red there also. If we come on to frailty assessment, we heard quite a lot about frailty and the importance of frailty in Angeline's presentation. The proportion of patients aged 65 years or over in whom a formal assessment of frailty was documented. That is the standard against which NELA will benchmark. Again, that comes from the high-risk general surgical patient, but also from the guideline for perioperative care for people living with frailty undergoing elective and emergency surgery that was published from CPOC with the BGS. The process measure will be the proportion of patients aged 65 years or over in whom a formal assessment of frailty was documented. And the benchmark for that will be 75% for a green RAG rating, and the other boundaries you can see at the top. CT scanning and reporting. The proportion of patients who had a CT scan that was reported by a senior radiologist and communicated with the team in the correct timescale. Now, this is already existing in the emergency laparotomy data set, and that standard comes from the high-risk general surgical patient raising the standard document. There are 2 process measures that allow us to benchmark against this standard. So the first one is, where appropriate, the proportion of patients who had a CT scan that was reported by a senior radiologist within 1 hour of the scan being undertaken. And the second process measure is, where appropriate, the proportion of all patients who undergo CT scan and where there is direct communication between the radiologist and surgeon, either via phone or in person, to discuss those CT findings. And again, the green RAG rating for that is greater or equal to 85%. Then we move on to the new standards. So advanced care plan, the proportion of patients in whom staff have proactively identified advanced care plans to support the decision-making process preoperatively. So this standard comes from the high-risk general surgical patient document and also the guideline for perioperative care. The process measure is the proportion of patients where the admitting team attempted to ascertain the presence of an advanced care plan preoperatively. And the RAG rating for that is greater than 85%. And then end-of-life care. The proportion of patients in whom assessment to identify need for end-of-life care is documented, and also the proportion of patients who are then referred to the palliative care team. Those are the two standards against which we're going to benchmark. And these standards come from two documents: End-of-Life Care for Adults, the NICE guidelines, and also this document from the Royal College of Surgeons, Caring for Patients Nearing the End of Life. The two process measures that we're going to use to benchmark that standard is for those patients who died in hospital, the proportion of patients with documented assessment to identify the need for end-of-life care. And for those patients who died in hospital, the proportion of patients requiring end-of-life care who've had formal referral to a palliative care team documented. And again, the RAG rating for that is greater than 85%. So just to reiterate, all these documents are available now on the website, and more detail about the source of the standard and all the links to the documents are also there. So I think we can move on now to start to tackle any of the questions that you may have for us about this process being implemented in April. So I'm going to hand over to Christine. There are a few more questions that have come in.
Yeah, please do keep them coming as you think of any questions that you may have. So some of them our team are typing some responses to. I'll try to take some and I'll try to direct them to the right people. So there's a question here: can you confirm that bowel obstruction with or without ischemia is excluded? Ineng, do you want to answer that one?
So we'll only take for the first year suspected bowel ischemia and bowel perforation. So the reference will be on the documents that we've published, the inclusion and exclusion criteria. So for bowel obstruction, so if a patient has had surgery, then no be excluded. But if a patient has bowel obstruction with bowel ischemia, I think we will include this patient in the audit if the patient has not had emergency laparotomy or any operative procedures.
Lovely. Thanks, Ineng. Hopefully that answers the question. We had a question come in for Angeline. How do you explain the difference between the studies, one all dead at 1 year and one with 26% still alive? Angeline, would you like to answer?
Yeah, thanks. So I think it comes down to the slightly different recruitment processes between the studies and the size of the sample. So the Australian study to start with, they identified NoLap patients through patients who died, so all of their patients were going to have died. The Danish study was quite a small sample of NoLap patients, only 21, and there was quite a high incidence of ischemic bowel in that sample, which might explain the very high mortality rate. ELF2 recruited patients across any specialty as long as they've been reviewed by a surgeon, so a slightly different patient mix. But I think the differences between the studies really does highlight the importance of this project, and that we really, really do need to understand this patient group a lot better. And hopefully by collecting data on a larger scale, more widespread, we can start to understand a bit better what the outcomes actually are for this group of patients.
Thank you, Angeline. Let's see. So we've had a question come in more about process for how we implement NoLap. So what if a trust is unable to appoint a NoLap clinical lead? Who'd like to tackle that? Lindsay, would you like to maybe weigh in on that one?
Yeah, there's a few questions. I'm just scrolling down that have kind of come in about, you know, the kind of practicalities of how you go about collecting data. Somebody else has said it. So is it mandatory to sign up to NoLap? I think there isn't a question about signing up to NoLap. This is something that has been commissioned by the Healthcare Quality Improvement Partnership. NELA are implementing this as part of our audit. We have been commissioned as the provider to be able to do this. So it's not whether it's mandatory to NELA to sign up. It is mandatory because it's one of the mandatory national audits that are run by HQIP. So yes, it is mandatory to collect the NoLap data from April. In terms of if there's not a NoLap lead that can be appointed, I think what we're really cognizant of is that throughout all of the NELA work that we've done, it's really clear that every organisation that works really hard to contribute data to NELA is really heterogeneous, and the infrastructures that are within each organisation are so totally different. And so we can recommend what we think would be the most appropriate thing, and ideally having a NoLap lead would be very helpful. But if that's not possible within your organisation, then it's up to the individual organisations to kind of work out what that workaround could be. Somebody else has just put, what is the role of anaesthetist in the NoLap audit? Well, it kind of comes back to shared decision making, and it's not just shared decision making with the patient, but it's actually making a bedside decision about the level of risk from an anaesthetic perspective, also about the ITU admission, getting critical care on board, meeting expectations of the patient and giving a really realistic overview of what that patient pathway could look like with surgery. So I do think there is definitely a role for anaesthetists in NoLap decision making. How there is a role for the anaesthetist in terms of the NoLap data capture, that's for individual organisations to come up with.
Thanks, Lindsay. I also just wanted to introduce one of our other panel members who wasn't on at the start of the webinar. That's Carolyn Johnston. Welcome, Carolyn. Carolyn is our quality improvement lead for the NELA project, and she's also here and available to answer any questions. Carolyn, there is a question that I think you might be the most appropriate person to respond to that's come in about Caldecott Guardians. Is patient identifiable information included, and therefore is Caldecott Guardian approval required? Would you be able to speak to that?
Yes, so NELA has a CAG exemption from Caldecott Guardian requirement to share the data externally. That means that we've been to the national body to apply for an exemption for NELA because the patients are, kind of very sick and often move through the hospital very quickly. So when NELA was first commissioned, it got this exemption from needing specific patient consent to share data. So that fits outside the national data opt-out and outside the Caldecott Guardian requirements. I'm just trying to get clarification that our NoLap patients are under the same CAG exemption. I think that they are. So I'll just confirm that in the chat because I'm just going through my paperwork to just double check before I say it. But as you know, for NELA, we don't get patient level consent. And so although it's patient identifiable data, it's exempt from the usual consent processes because we've been through a national process that means we don't need to get consent on a patient-to-patient basis. So you would not need Caldecott Guardian approval to share this data outside the trust.
And Carolyn, just on the CAG exemption, I can confirm that. So NELA does have CAG approval to collect data without consent on the group of patients that comprise
NoLap patients. Yeah, it's good.
All right, we have another question about CT scanning. So for the CT scan standard, will an outsourced CT scan report be able to count? Lindsay, would you like to respond to that?
Yeah, absolutely. Outsourcing is something that is not going away. In fact, we know that the numbers of outsourced reporting is going up. What we need to try and do is maintain a high standard of care for those patients who have an outsourced CT report. So a conversation and communication between the outsourcing service and surgical team would be essential to meet that CT standard.
Thanks, Lindsay. We had another similar question about outsourcing, so I think that you've probably answered that now. Yeah, NELA does now consider outsourced reports to meet our reporting standards, so those will count.
Just to jump in again, I've just seen someone that says something about most hospitals move to outsource radiologist reporting. These are accredited radiologists. Why is their reporting not considered as a good standard? So they are, there has been some evidence to suggest that there is a higher discrepancy rate between outsourcing of reports compared with in-house reporting. And we've presented that previously in our NELA data set as well. The standard really is the communication element, and if somebody's outsourced, then that makes communication a little bit more challenging perhaps, but it's not something that is impossible to overcome. So I just wanted to clarify that.
Thanks, Lindsay. We've had a question about annual reporting. So will NoLap data be included in the annual report for NELA for each hospital? I think I can answer that. So yes, there will be an annual reporting process for the NoLap cohort alongside the surgical operative cohort. What that looks like is still being sorted behind the scenes, whether or not we issue one report that includes data on both cohorts, or if we issue two separate reports. So that's still pending, but yes, we will be reporting the data on an annual basis for NoLap, and it will be done at hospital level the same way that the surgical cohort data is presented. Let's see what else has come through. So, sorry, I can't dismiss that one. Okay.
Quite a lot of questions about the data collection in the database, aren't there? There seems to be a lot of people questioning the database, so perhaps that would be a good one to answer.
Do you want to pick one out in particular, Lindsay?
There's lots, basically saying how will the data be captured and recorded from NoLap? Will there be a second database? Is it going on the same database? Is it going to get really confusing? It will be through the NELA website, but it will essentially be into a separate data set that goes alongside the NELA data. So it will be, has this patient had an emergency laparotomy, yes or no? And then it opens up two different data sets.
Yeah, and we've tried to issue some comms out to all of our local NELA leads, and hopefully that's been disseminated further. But from April, NELA are transitioning from our current website to a new website. So data collection may look a little bit different in general than what you're used to. But when you come to that landing page, you will be presented with either a NoLap kind of patient data set or a surgical patient data set, and you'll be able to decide then and there kind of which data set the patient falls into. So it will be collected as part of the same process, just using a slightly different, I guess, questionnaire on the website. Let's see. So we've got I think I've seen a few questions about tariffs and best practice tariffs coming in for the NoLap group. At this point, I'm not aware of a best practice tariff that will go hand in hand with the NoLap cohort, but that may change in future, so I don't have any info about that. Your suggestion of a link person checking in with the surgical take daily. Ooh, sorry, that one's just gone from my list. We've got a question come in for the patient groups you are starting with, perforation or ischemia. What's the 30-day mortality rate? Angeline, are you able to tackle that, or Enang, based on previous research? Maybe even Hannah?
So I wasn't sure whether the question meant the 30-day mortality for NoLap patients specifically with those diagnoses, or patients who underwent surgery. I think in relation to the NoLap patients, ELF2 will provide this information. So as soon as we can get that published, the better. In terms of patients who have surgery, I'm sorry, I don't know that figure off the top of my head.
Hannah will know that off the top of her head, I'm sure.
I actually don't, but for ischemia, it's definitely higher than the average. So NELA's average is 9.1 or 9.7% at the moment. I do know that ischemia is significantly higher than that.
It's definitely in the year 8 report.
Which is, yeah, now been published and available if anyone wants to take a look. We've had a question come in. Will there be monthly reporting available on the results of the key standards? We have this for the NELA cohort, and it's really helpful to see quickly where we need to improve. I think we will be looking into this in future. It probably won't be available from day one of the NoLap audit, but it is something that we will work to provide as the audit kind of gets up and running and is a bit more established. So yes, plans there to do that. We've had a lot of people expressing an interest for diagnostic codes for the NoLap. Some people have sent in their email addresses, but that's potentially something else that we could share on our website. Inang, do you want to speak to that?
Yes, so I've got the list of email addresses I'm collecting as people put their email addresses in, but also once we will upload the list of diagnostic codes as soon as it's available on the website. So yeah, will be available to everyone.
Great. Another question about kind of the diagnoses. So are you defining bowel ischemia with specific criteria, i.e. lactate or CT? I ask because sometimes CTs can overcall ischemic changes. Who would like to tackle that one? Lindsay, go for it.
Yeah, so I think what we've said is CT suspicious for ischemia. So whilst I accept that CT can overcall ischemia, there are a lot of other things that can cause a high lactate that isn't necessarily ischemia. And if you've got something where you've got a volvulus that's resulted in ischemia, you may even not get a raised lactate because you've compromised the venous return from the ischemic segment of bowel. So we're not going on lactate for that. It's CT suspicion of ischemia.
Okay. I'm not sure if we've answered this, but we've kind of hit on it previously. There's a question: will it be more pragmatic to appoint a NoLap lead from within the surgery division? I think personally, it probably depends on how each unit is set up and how they work. Maybe different perspectives. I don't know. It might be nice to kind of get a few different views from the panel. Who would like to start? Inang, do you want to have a first pass at that, and maybe we can get some other thoughts from the panel as well?
Sorry, I missed that. Can you repeat the question again?
Yeah, so someone's just asking if it would be more pragmatic to appoint a NoLap lead from within the surgery department.
So I think that's a suggestion from the NELA team. As we've seen with the operative registry, having a NELA lead is quite a helpful thing, and it's also served as a point of contact between the local trust and NELA project team. But things work differently between trusts, so we can only suggest what we think will work, and I think it will be depends on how the trust functions most effectively to try to capture these patients. We recognise that this is going to be a more challenging group of patients to capture compared to the operative groups, because they do not have a defined episode in their hospital stay. We'll just have to accept this for the first year, and then hopefully in years to come, things will get better as we go along. Yeah, so I don't know if anyone has anything else to add on this, but this is my thoughts on that. Thank you.
I'll chip in if that's all right. I think this is NoLap's going to require buy-in from lots of different teams, including the surgical team quite heavily, particularly the surgical juniors and registrars. And I think people should maybe consider that registrars and trainees could be NELA leads within a trust to take ownership of data collection. And we need to think perhaps outside of the box in terms of how we get it done on a day-to-day, monthly basis.
Yeah, as Seth mentioned, it doesn't have to be a consultant, so it can be just any trainee or SAS doctors or anyone who is interested to lead on a project, and it will serve as a good sort of project to take on during their time in the trust. Yeah.
Great. Did anybody else want to come in on
The only thing I'd say is to consider nursing and allied health professionals colleagues as well. So lots of trusts have got advanced practitioners working in acute general surgery. There might be specialist nurses or other AHPs that might also want some experience. So just to think how you can widen the team.
Great, thanks everybody for that. A question related, going back to the CT standards, I believe there's a question that's come in. Do radiologists need to speak on the phone with EPR reports in real time in order to, I think, to meet our standard of care? Lindsay, one for you.
Yeah, so it's yes, they do effectively. So it is a way of ensuring that all the concerns raised by the clinician are answered in the radiology report, and that images potentially should be looked at together wherever possible. These are the sorts of standards of care that are described in the high-risk surgical patient raising the standards document. And that is where the standard has come from. I think there is a lot of work gone into that Royal College document, and it's been published now for 5 years, and there are some really quite hard-hitting standards that we're still not meeting across lots of different areas of this acute care pathway for these emergency laparotomy patients, or NoLap patients as they may be. And so that document is definitely worth reading, because it's my impression that almost every organisation is well behind with what those standards have described, and that document being 5 years old is almost certainly going to be due for a re-edition in the near future, and it may become even more hard-hitting. So organisations have really got to look at what they're doing.
Thank you, Lindsay. We've had a question come in about funding. Will there be any additional funding associated with NoLap? The answer to that question is no. Even the NELA team itself are not receiving additional funding from HQIP to get this done. So no additional funding associated with NoLap. Let's see. We've had a question about deadlines for data entry. So is the deadline for NoLap data upload the same as usual NELA data upload, i.e. within 2 months? So yes, I think this is kind of yet to be kind of discussed formally, but yes, we would imagine that timelines will be quite similar to what we do with the operative cohort, in that the data collection period will last for a one year term, and at the end of that term, all sites will have about 2 months to then go back, review all their cases, make sure it's all accurate, and lock the cases before we export anything to do a formal analysis. So yes, reporting and data timelines will largely mirror those for the operative cohort. Let's see. There's a question about posters. Posters will be good to have them back, as we will be able to show all the teams how we're performing. This is a query that we've had come into the inbox quite a lot since we've removed that functionality. The functionality was removed because we made some updates to the background calculations for some of our standards, which meant that the posters weren't running correctly. So those have been pulled for the time being, but there is the intention to update those calculations on the back end and get those posters back up and running. That will probably happen post-April, after all of our other changes that are coming from April have been implemented. So yes, stay tuned on that, and we'll send out some comms once those are available again. What else do we have?
I think the other thing about the posters, Christine, is just to say that, you know, for those who haven't used that poster function, it really was really, really helpful. So if you haven't used it before and you get comms saying the posters are back, go and take a look, because as people have said, you know, they really are really useful at organisational level.
Yeah, thanks for that. Will NoLap leads need to be registered as leads on NELA for NoLap? I think the answer to that question is yes. So we would like any hospital that is able to identify a NoLap lead, if you can send us their details, we can add them to our contact list. And if they're new to the NELA system, we can make sure that they get set up with the appropriate credentials to access the site kind of on an admin level to be able to track progress specifically for NoLap. So, so yes, if you've identified a local NoLap lead, our email address is nela@rcoa.ac.uk. You can email those details to us and we'll get them set up on the database and put them on our mailing list. Let's see. Will a recording of this webinar be made available as there are colleagues who unfortunately are not able to attend today? Yes, absolutely. It'll take us some time just to pull it from the website to get it edited down slightly, but then it'll be posted and we'll send it out to everyone who's registered to attend today. So you'll get a copy of it coming through. Let's see. Anything else that we haven't tackled or any other questions, keep them coming. We've still got about 8 minutes left in the webinar. I'm going to try to look at some of the longer ones, or if anybody else on the panel has seen one that they think is worthy of discussion, please shout out.
Yeah, Christine, I was just going to talk about there's lots of questions about PA allocations, and it's something that we get asked quite often, both in NELA and other college projects, about whether there's a specific PA allocation for a role. This is something that gets talked at a lot, both within specific projects, but also by the clinical leads network within the Royal College of Anaesthetists as well, because they're obviously all the clinical leads that are responsible for giving you that PA time in your job as well. There's not a specific PA allocation for a NELA lead or a NoLap lead or any of those leads, because it's really dependent on your local level of support, the teamwork, the amount of work that you undertake in that lead role, and of course your case mix. And so it would be very difficult to specify a PA value attached to being a local NELA lead, except to say that the job description does detail for NELA leads anyway, and for NoLap leads, because we're getting a strong message that you would like that job description. But the PA allocation would depend on the amount of work that's done, and that the job description details the amount of work that we would advise a NELA lead undertakes. So our advice would be that you kind of take that list of descriptions and estimate the amount of time that would take you and take that to your job plan meeting with your clinical lead. I suppose it would be nicer if we said everyone can have 5 PAs for this, but it's just not possible because there's such a variety of different units and different support mechanisms. You know, some of you I know are working by yourself to collect all the data and working very hard every day on it, and other people have a lovely audit team of support around them that's giving them lots of support and collecting a lot of the data for them. So the idea that we could kind of summarize all of that into one PA allocation is very difficult, and that's why the PA allocation isn't there.
That's great. Thanks, Carolyn.
I was just going to mention there's been a few questions that I've answered in the chat about the end-of-life care and advanced care planning standards. So we recognise that end-of-life care, individual end-of-life care plans will look different by trust. So we're not looking for you to follow a specific end-of-life care format, but it's whatever is used in your trust, and that it's documented in the notes that that's what you've done. In terms of the advanced care planning and ascertaining the presence of an advanced care plan, again, we recognise that it may not be possible to get that information on your first attempt, but any indication in the notes that an advanced care plan has been considered and there's been an attempt to try to determine whether that information exists is what we're looking for. And there was a question about why is geriatrician input not being recorded for patients who survive? We will be collecting that information. It's just not formed one of the standards for year one, but we will be looking at the data to see what happens with these patients, and I'm sure that the audit will evolve in future years.
Thanks, Angeline. There's a question about, we've said the recording for this will be available after the event. Will the slides be available as well? I think that's up to presenters. If they're happy to share, we can certainly get them posted as well. Oh, We do have one other question that's just popped in. Are you collecting discharge destination for the survivors? So the pro forma has been drafted and has been uploaded. I think the short answer to this is no, we're not. I don't know if anybody wants to go into that. It's not something that we collect for our surgical cohort either. I think traditionally the data has been quite poor, which is why we don't try to ascertain that information. Does anyone want to come in with more on that?
Yeah, so again, I think it relates a lot to the heterogeneity that we see nationally. So a number of these patients who are potentially survivors will be discharged to, for example, an intermediate care facility. And intermediate care is very different across all different areas of the country. For some, that's returned to their own home with a sort of heightened package of care and reablement service. And for others, it's admission to sort of a discharge facility where they receive that level of care and reablement. So collecting discharge destination is notoriously difficult. It was collected in the ELF study though, I think, Angeline. So it's not something that we're collecting, but Angeline may be able to talk a little bit more around where we see patients discharged to after emergency laparotomy.
Yeah, so there will be some information published with the L2 results around discharge destination. But as Lindsay's and Christine have already pertained to, it's very difficult to capture accurate data on this because not just differences between intermediate care, but differentiating between residential care, nursing care, formal care at home, informal care at home. So it is very difficult. It's not to say that we can't do it in the future, but I think the focus of the audit at the minute is to collect information on who these patients are, what happens in hospital, and then build on from that. But do look out for L2 results in the near future.
Lovely. So I don't see any more questions that are pending response. So I think we can probably let everybody go with 2 minutes back in their day. Thanks to everybody who's attended and joined today and asked some really great questions. Hopefully that gives everybody some helpful information going into the data collection for NoLap coming your way in April. The website does have a lot of the resources that have been mentioned today. We'll get those uploaded, updated with the diagnostic codes as well, because there was a lot of interest in that. We will also send out further updates as and when we have them. Please do fill out the survey that's coming your way once we close down the webinar. And if you have any other questions between now and April, again, the email address for us, it's nela@rcoa.ac.uk. And with that, we'll let everybody on their way. Thanks again.
Thank you.
Thank you.